Good morning, good afternoon, good evening, all, depending on where you are, and welcome to this webinar using health accounts to inform health financing policy. I am Tesfaye Ashagari. I am the resource tracking lead within the Health Financing Governance Project, HFG in short. It's a USAID-funded global flagship project. I'm pleased to welcome you to this technical session. This webinar is part of the briefings on the challenges and best practices that we have gathered through the work that we do within the HFG project. As we all know, health financing is one of the key areas of focus in the countries moving towards achieving universal health coverage goals. Understanding the size of the pie and how they are sliced, how it is sliced to finance the different health priorities is a critical input, as you know, for evidence-based policy and planning, as well as monitoring the effectiveness of the policies that are in place. And health accounts, by its nature, we'll see it in a little while, is at the core of the resource tracking frameworks. Joining me today in the webinar are two of my colleagues, Karishmah Bhuwanee and Cogswell. Both have, as part of the resource tracking team, have been supporting countries in rolling out health accounts, especially the new updated System of Health Accounts 2011 framework. Please note that we will take time to take time for questions at the end of the session, but we encourage you to pose the questions as you go along so that we can be able to compile them and try to answer them in the order they come in. With that, I'll let Karishmah take over. Thank you.
Thanks, Tesfaye. So I'll just give you a brief outline of today's discussion. We're going to start with a brief overview of health accounts and what it is. And then we'll look at how health accounts have been used to inform the three key dimensions of health financing, and that's resource mobilization, pooling, and purchasing. So with that, I'll hand over to my colleague, Heather.
Thank you, Karishmah. So I'll get us started with an overview of what health accounts are. And to put it very simply, health accounts is a way of determining a nation's health spending patterns. System of Health Accounts, or SHA 2011, is the internationally recognized framework that is the foundation of the health accounts process. And so during today's presentation, you may hear us refer to health accounts or SHA 2011 interchangeably. So as countries conduct the process of health accounts, they systematically track both the magnitude, so the total amount of funding in the country for health, and the flow of that funding through the health sector. And SHA 2011 is a comprehensive approach. And when we say that, we mean that it looks at total expenditures from all sources, including public, private, and donor contributions, as well as across both current and capital expenditures and across all disease areas. And SHA describes expenditures for all health activities in one country, although it can be done subnationally, and for 1 year at a time, and usually it's the government's fiscal year. And in terms of what comes out of health accounts, the output is a standard set of tables that use the internationally standardized SHA 2011 codes. And it's this standardization that allows for the comparability of health expenditures both across countries and over time. And really, the entire reason countries do this, the purpose of health accounts, is to generate consistent and comprehensive data on health spending in the country, which in turn can contribute to evidence-based policymaking. So health resource tracking is not new. Countries have been tracking their spending since the 1950s, and health accounts using the official SHA framework have been produced for the past 15 years. So the map that we're looking at here shows countries that have conducted health accounts with SHA 2011. So that is all exercises since 2010. And you can see from the countries represented that over 80 exercises have been conducted across 55 countries to date. One interesting thing to note is that up until 2010, it was predominantly high-income countries that were producing health accounts. And in fact, 97% of high-income countries produced health accounts versus only 6% of low-income countries. And so recently, there's really been a big push to support low and middle-income countries to assist them in producing health accounts data. And you can see from the countries represented on this graph that this push is being successful. Karishma mentioned that today we're going to be talking about health accounts in the context of the three basic parts of health financing. And this arrow here shows those three parts. So obviously you need to start with first generating revenue for health, and then once you have that revenue, you need to manage it in some way and ultimately use it to purchase health goods and services. And so the health accounts methodology follows this same flow of funds, starting with how funds are raised all the way down to how they're used. So when I pull up this second arrow, this shows the Shaw 2011 classifications that provide snapshots of health expenditures along each stage of the flow. And for the purpose of today's presentation, we don't want to get into all of the nitty-gritty details of each of these classifications, but we just want to show how each of these three health financing functions can be clarified with health accounts data. So to start off, in terms of raising revenue for health, health accounts helps us answer the question of how are resources raised. And an example of how resources are raised may be a transfer from the Ministry of Finance to the Ministry of Health or to some other government agency. Moving along to the process of managing and pooling resources, health accounts allows us to answer these two questions. First, how are the funds managed? And then second, who manages the funds? So what is the institution or entity that's the actual manager? And so an example of how funds are managed may be through an employer-based insurance scheme, and then the institution or the entity that's managing that would be the insurer. And then finally, when we get to purchasing services, there you can see there are several classifications. The first answers the question of who actually delivers the health goods and services. And these would be institutions such as hospitals or clinics or pharmacies. When we get to the next level, we're talking about different types of inputs that are consumed in the delivery of health goods and services. So you can think of this as maybe staff wages or salaries or equipment or medical goods. When we get to the healthcare functions, we're talking about the type of services that are delivered. So was it for curative care, prevention, health system administration, etc. And then finally, we end with describing the specific characteristics of the population that was treated. And so this encompasses things such as the diseases, the age and gender of those beneficiaries. So this is a high-level overview, but you can see that health accounts provides really a comprehensive view of health expenditures in a country. And so with this overview, we're now going to walk through country applications of health accounts data at each of these three health financing functions. So we'll start with the first one, which is resource mobilization. One policy question that a lot of countries grapple with is how sustainable is our financing for health? And health accounts provides information about who is financing healthcare in a country. And if you have multiple years of health accounts data, you can see the trend in that financing. And obviously, this is of interest in our era of declining donor resources, where countries are being forced to make sure that they're raising revenues in a financially sustainable way, meaning they're decreasing their reliance on external and donor sources and increasing domestic revenues for health. So if we look at the graph displayed here, you can see data for 27 countries, predominantly low and middle income countries. And the graph displays the share of government spending on health out of total health spending within each country. You can see across income groups that typically the share of government spending is increasing, and within income groups there is variation in the share of government spending. Focusing on the left-hand side of the graph, the low-income group, you can see that almost half of the countries in that group have government spending representing less than 20% of total health spending, which is on the low side. And so countries can use data like this to conduct deeper dives around particular health service or disease areas that have low government funding or particularly high donor funding, and they can use this information to develop plans to sustainably fund these areas going forward. Let's look at a particular country example. This one is in India, where health accounts data helped inform resource mobilization. I'll start out by saying that this example is from the results of the 2004-05 health accounts in India, and so while it's a little bit dated, the findings were an influential milestone in the country, so this example is still quite relevant to discuss here today. So as I mentioned, India conducted a health account covering the 2004-05 fiscal year, and the results of this study showed very low public spending for health and really high out-of-pocket spending for health. And in fact, if you look at the data, which isn't displayed here now, but households were the source of over 71% of the funds for health in the country, and most of this household funding was out-of-pocket. And in contrast, government spending represented less than 20% of total health expenditure. And so this high share of out-of-pocket spending reflects a considerable financial burden on households. And this level of out-of-pocket spending is much higher than what is observed in many developing countries. And so it was really these findings from health accounts that prompted the National Commission on Macroeconomics and Health to encourage the government to establish the National Rural Health Mission in India. So NRHM was established in 2005, and one of its key goals was to increase public financing for health. And so in that same vein, to begin to reduce out-of-pocket spending, the government developed new government-funded pro-poor insurance schemes, some of which were run by NRHM. And in addition, the graph that's displayed on this slide shows that NRHM led to an additional almost $3.3 billion US invested in the health sector between 2005 and 2009. So the figures here are in Indian rupees, but that's the approximate conversion. And so health accounts data contributed to the generation of substantial resources for health through this process. Another country example we wanted to highlight was in Ethiopia, where they were able to mobilize additional resources for health through revenue retention at health facilities. So in 2003-04, Ethiopia's health accounts highlighted very low investments in health. You can see in the graph on this page, the middle bar is the 2003-04 results. So total health spending per capita was around $7 US, and in the years before that, it was still quite low. And so as a result of this data, there was really a constant push on all fronts to begin to increase resources for health. And you can see that increase in health represented in later years of health accounts data. But in addition, during this time, spending by government was growing nominally. So government spending on health increased substantially by about 67% between 2007-08 and 2010-11. And in addition to the nominal growth, total government spending on health as a share of the government's general expenditure also increased during that time. So from 5% to 5.6% in 2010 and 11. And this increase was really the result of advocacy from health accounts data findings. And so in terms of the revenue retention example, there were many factors that contributed to increased funding. An example of one way in which Ethiopia mobilized resources for health to achieve this increase was through revenue retention at the health facility level. And so health accounts data was combined with other sources of data to show that spending on health was low, and there was low perceived quality of care at the facility level. And so the revenue retention policy enabled health facilities to keep user fees that they earned and reinvest them in the facility. And these retained revenues were used on things such as improving infrastructure at the facilities, training staff, and purchasing drugs, etc. I just wanted to show a quick before and after picture. So this is part of the Shaftu Hospital. I'm not remembering if it's the pharmacy or the lab, but you can see that before revenue retention and after, there was a drastic change in the infrastructure of the facility. And finally, one last question we wanted to talk about in terms of resource mobilization was a question that many countries grapple with: is health funding sufficient to achieve international benchmarks? And countries can use health account spending data to measure their progress towards benchmarks and their progress in relation to their peers. So in 2009, the Task Force on Innovative International Financing for Health Systems identified an internationally accepted essential package of health services, which was valued at $60 US per capita. You can see that represented by the red line in this graph. And this package of services included essential, affordable, and high-impact interventions. And what you can see in the data on this page is that most low and middle income countries are spending less on health per capita than this target. And so data like this can be used to advocate for additional resources for health in countries. And this is just one example, but the results can help countries monitor progress against these targets and benchmarks, particularly if countries have multiple years of data and can see trends over time of how things are improving or not. So with that, I'm going to hand it off to Karishma now to bring us through the remaining two functions.
Thanks, Heather. So I'll move on to the second part of health financing, which is about risk pooling. Risk pooling is about combining resources across a large group of the population in order to pay for the services for everyone who needs it. Risk pooling helps countries to make health spending more equitable so that the payments are based on ability to pay and so that no one person incurs a high financial burden. Increasing risk pooling and reducing direct payments is one of the three dimensions that countries have to address to achieve universal health coverage. And when we talk about risk pooling, some examples are prepayment schemes such as insurance and also government schemes that are funded through tax revenues. So health accounts breaks down total spending between risk pooling schemes versus direct payment schemes. And at a macro level, they can help to identify where there are opportunities to increase risk pooling. The chart that you see here shows the breakdown of spending by out-of-pocket, which is in gray, by voluntary insurance, which is in orange, and by government, which is in blue. So as you can see, some countries, such as Namibia, which is second from the right, are already pooling a large percentage of their resources through government and insurance schemes. This is in contrast to countries on the left, like Cambodia and Niger, that still have a high percentage of spending coming from direct out-of-pocket payments. So countries can use health accounts to measure how their resources are pooled, and this can be used as an advocacy tool to either establish more risk pooling schemes or to expand existing ones. Another question that countries must understand to achieve universal health coverage is whether households are incurring catastrophic spending to access health. As I mentioned, health accounts can tell us how much of total health is from out-of-pocket. But countries can also combine this information with wealth quintile data to see which quintiles are spending out-of-pocket and the extent of catastrophic spending. So, for example, is it poorer households that are incurring catastrophic spending, which is affecting their access to care? Or is high spending driven by wealthier quintiles who are spending out-of-pocket for health because they prefer private care? The chart here shows the percentage of total health spending that's from out-of-pocket. The red bar across the chart is where out-of-pocket is between 15 to 20% of health spending. And a WHO study in 2010 showed that when out-of-pocket spending is above this line, the risk of catastrophic spending and impoverishment increases significantly. So countries can use health accounts to benchmark themselves against this indicator, but also against peer and their neighboring countries. Health accounts can also be used to analyze what services households are spending out-of-pocket for and which types of disease or conditions are driving the spending. And these can help to inform essential package of services or benefit packages for insurance. Health accounts can also show where households are spending out-of-pocket, for example, which type of providers. and this can give indications about household preferences. For example, a lot of countries have seen that households spend a lot out of pocket for private care, even for services that are available in the public sector, and this has highlighted quality issues in the public sector. So let's move to a country example, which is Indonesia. Since 2011, Indonesia has been expanding the population coverage and the benefits of its pro-poor insurance scheme called Jamkisma. Health accounts have shown that during the same period, out-of-pocket spending has been falling. We don't have the detailed data, but further analysis could also be conducted with wealth quintile information to confirm whether this fall in out-of-pocket is occurring for the target group of this insurance scheme. And in 2014, Indonesia combined 5 existing insurance schemes under one umbrella to form a national health insurance called JKN. Preliminary results from the 2014 health accounts are showing a further decrease in out-of-pocket since the start of JKN. And JKN will be expanding until 2019, when Indonesia expects to achieve universal health coverage. So the health accounts will be a key tool to track that JKN continues to be effective in reducing out-of-pocket spending. And as more and more funding flows through JKN, health accounts will be used to track the services that are being used by JKN members and the most common diseases and conditions that are being treated. And this information can be used to ensure that the benefit packages are still relevant. Health accounts will also be able to show which providers are spending the most for JKN members to ensure that public and private providers are participating in the scheme as intended. Another country example is from Egypt, and Egypt was one of the first developing countries in the world to conduct health accounts in the mid-90s. This data is several years old, but still a relevant example of how health accounts can be used. As the health insurance scheme increased its population coverage, Egypt used health accounts to show how effective this health insurance program was in providing financial risk protection. The chart on the left shows you the percentage of the population covered by health insurance, and the chart on the right shows out-of-pocket spending. As you can see, even though population coverage for insurance was increasing, during the same period, out-of-pocket spending was also increasing. So at a macro level, this helped Egypt to gauge whether their health insurance program was actually working. It led stakeholders to move discussions away from just population coverage to looking at effective coverage and reviewing their enrollment methods, the benefit package, and the premium contributions to ensure that the health insurance was really providing the coverage that households needed. Now moving on to the final dimension of health financing, which is purchasing. The purchasing function is about how the pooled resources are allocated to providers in order to purchase goods and services. It answers key questions like what services are paid for, which providers are allocated funding, and what are the mechanisms for paying these providers. Now there are some key purchasing questions that countries must have a good grasp of. For example, does health spending respond to the disease burden in the country? Countries can use health accounts with disease burden and costing data to understand whether health spending may need reallocations. Similarly, policymakers have to ensure that their spending is aligned with the priorities that were set in national strategic plans. And by comparing health accounts with costed plans, policymakers can track whether the spending is being allocated to the areas that will help to achieve national targets. A third question is about efficiency. Before advocating for more money for health, it's important to show that existing funds are being used efficiently. Ministries of health can use health accounts with health indicators to show what has been achieved with the money provided to them by the Ministry of Finance and donors. And by benchmarking with countries with similar spending levels, it can help to identify where there might be lessons learned for improving efficiency. Namibia is an example where health accounts were used to reallocate resources to national priorities. Reproductive health in Namibia is a national priority, and in the 2008 health accounts, it represented 10% of spending. Most of the spending, however, came from households, and was during a time where maternal mortality rates were increasing. And this was in comparison to HIV/AIDS spending, which represented 29% of health spending and which exceeded costing estimates for HIV/AIDS. Based on these findings, policymakers in Namibia used the health accounts to increase the government's contribution to reproductive health. And by 2012-13, the health accounts showed that reproductive health represented 38% of total spending. And what's encouraging is that health accounts showed that the majority of that increase came from government, and government now accounts for 70% of reproductive health spending. And the contribution from households had fallen to 7%. Now, with such a large increase in reproductive health spending, you can imagine that health accounts have also encouraged discussions about efficiency. And this is something that Namibia is exploring with the support of HFG. Countries in the Caribbean have also used health accounts to align their spending with the disease burden. The latest health accounts in Barbados and Dominica showed low levels of spending, around 3 to 4%. And at the same time, NCDs account for 80% in these countries. Now, these governments have recognized that treating this increased burden of NCDs is just financially unsustainable, and that prevention and promotion, like promoting healthy lifestyle, is key to this national response. So last year, Barbados and Dominica introduced excise taxes for sugary foods and drinks. The revenues from these taxes will be used for health spending, and there's a push to also use this for health prevention and promotion. I talked about efficiency, and health accounts provide an entry point for looking at efficiency. And we can do this by comparing spending data from health accounts with outputs to see what was achieved with the resources that were spent. In the charts here, we've compared spending with output indicators. For example, on the left, you see maternal health spending per capita against institutional deliveries. And on the right is family spending per capita against percentage of family planning needs met. And by per capita, we've used per woman of reproductive age. Now, obviously, many factors affect these output indicators. And with more data, we can identify the areas of spending that is closer to these output indicators. But at a very macro level, using health accounts in this way can highlight potential efficiency issues and can inform where countries might want to do more detailed analysis. And by showing countries how they're performing relative to their peers, or countries who are spending similar amounts, it can encourage cross-country learning. For example, in the left chart, both Liberia and Benin spend similar levels on maternal health, but Benin has a much higher percentage of institutional deliveries. On the right-hand chart, Burkina Faso and Sierra Leone both have similar percentage of family planning needs met, but at very different spending levels. These types of findings can help countries to learn more about how their peers are organizing the provision of maternal health and family planning services. So with that, I'll hand back to Tesfaye.
Thank you, Heather and Karishma. This is great. I wouldn't want to take up some time to summarize everything, but I just had 3 points to highlight from the presentation. One is that considering the comprehensiveness of health accounts in tracking resource magnitude and flow in the sector, it remains as a cornerstone for monitoring the country's financing landscape. And related to that, the second thing that I would like to highlight is that the examples that we saw provide just a glimpse of how information generated through the health accounts can help, especially combined with other data such as outputs, health outputs or outcomes, or even socioeconomic indicators, can have the capacity to inform both policy and plans as well as monitoring their effectiveness. The third point is a flag actually related to the second point that I made, given that this is just a glimpse and seeing that we have a good number of participants that are coming from the different walks of life, even the countries, the development partners. I would like to make a plug so that to get these stories, there are various stories out there so that we can be able to compile them for cross-learning purposes. So if you have any story to tell, please share with us so that we can be able to compile them. With this, before I open up to the panelists to answer a few of the questions that are coming in, I have one question for the two of you. That is, so what is the future for the health accounts? What are the challenges that you're seeing? Maybe let's start with that as we sort out the questions that are coming in.
Thanks, Tesfaye. So I can get us started and then Karishmah chime in. In terms of the future of health accounts, that gets to one of the challenges, which is making sure that countries are conducting health accounts on a regular basis so that the data is available to inform policy in a timely manner. And so one of the things that we as a team and in collaboration with WHO are constantly thinking about is institutionalization of health accounts. And when I say institutionalization, I'm talking about routine government-led production and utilization of the health accounts data, so that health accounts is something that's built into the system and that is funded and conducted with in-country capacity on a regular basis. And so HFG is supporting institutionalization in sort of two key ways. We're working to make the production of health accounts easier and more cost-effective. And then the second way is working on making sure that countries are able to transform the results into formats that are easily usable by policymakers. So I'll start with the production of health accounts. HFG has been working with WHO and partners to help refine some of the key tools that are involved in producing health accounts. You may have heard of the Health Accounts Production Tool software or the Health Accounts Analysis Tool software. These are both tools that are meant to make the onerous process of collecting and analyzing the data easier by walking country teams through the process step by step. And in addition to constantly testing and refining those tools, we've created a lot of guidance material and videos to help country teams get up to speed on that. We also regularly conduct trainings and workshops and peer learning events so that country teams can share their experiences and learn from each other. And another key thing that we're working on, so health accounts is a data-intensive process, and as much as possible, we work to try to streamline the process of collecting data so that we can use routine data collection that's already happening in country and build off of that so that those processes can inform the health accounts and that we're not collecting our own process in parallel to what the country is already doing. So those are some of the key aspects that we're working on the production side. Karishmah, do you want to maybe chime in on the use?
Sure. Another area for institutionalization is about disseminating health accounts data effectively and making sure that that data is packaged in a way that's really relevant for stakeholders. And HFG is helping countries to think through who their stakeholder groups are and to tailor dissemination formats to what those groups are interested in. So we're supporting countries to disseminate health accounts in a variety of different ways, like policy roundtables or workshops, panel discussions, or press releases. And on the use, it's really important that health accounts data is distilled in a way that responds to the questions and the issues the policymakers are grappling with. And health accounts are not always easy to interpret, and the results have to be made more user-friendly. And as we've shown today, health accounts alone can answer some questions, but the real value of health accounts is really maximized when it's combined with other data sets like costing studies or macroeconomic data and health status data.
All right. Thank you very much. So probably I think we can be able to start going through the questions from the participants. Probably I would start with the production side questions that were highlighted related to what is the tips that you can give us in terms of the challenge that we face in data collection, especially when it comes to development partners, as well as even the government. So what are the tips that you can give us is the first question.
Yeah, so I was mentioning before when I was talking about institutionalization that health accounts is very data intensive, and the process of collecting data in a timely manner and getting a complete set of data can be challenging. I think to the extent possible, so one of the key sources of data for health accounts is information on household spending. And so some countries choose to conduct their own household survey to collect health expenditure information, but that can be costly and very time intensive. So to the extent possible, if expenditure questions can be incorporated into existing mechanisms that the countries are already using to collect data, that can really help streamline the process and reduce the cost. Another data collection challenge that we've encountered across countries is that it can be hard. Collecting data from the private sector can be a challenge. Oftentimes response rates are low from employers and insurers. And so what we've seen is that as governments begin to recognize the importance of health accounts, they need to really work to strengthen the public-private relationships so that there's built trust and understanding of how health accounts data will be used and why it's important for the entire country, both public and private sectors, so that it can begin to streamline the process in future exercises.
All right. I think there was also a related question that was related to what are the common challenges. I believe these are also highlighted in the production process. One of the key challenges, as Heather mentioned, the data collection process. So how do we streamline it in such a way that we can get the maximum information from the partners or the respondents is one thing that we're trying to balance on. And part of the institutionalization also would entail how do we automate that process as well, so that respondents can think of these things beforehand, so that they can be able to provide the data and organize the data in such a way that what's needed. I
might just add one additional challenge, and this may be a factor of like our millennial group that's entering the workforce now, but in terms of institutionalization, you want to make sure that it's institutionalized within an entity or an organization and not within a person, because we've seen where there's one or two spearheads of health accounts, and when they leave the Ministry of Health or when they move somewhere else, then the institutionalization has been lost.
Okay. Thank you, Heather. So probably there is another question related to institutionalization, which is kind of related to where do you see the donor programs in terms of supporting health accounts in the near future? Do you see it continuing, even for countries that have, quote unquote, graduated into the next income level? Do you see the need for support there? So, and that's, with that, maybe probably we'll get back to other questions related to some components within the health accounts.
Thanks, Tesfaye. In terms of institutionalizing production and donor support, we're seeing a shift. With the release of the SHA 2011 framework, that update, there was a lot of support to help countries to understand the new framework and to produce the health accounts more cost effectively. But we're starting to see a trend towards now donors providing more targeted support. So countries are able to, they understand the framework, they can produce it themselves, but then technical assistance is really coming in to support one or two aspects of the more technical areas of health accounts. And we've seen countries like Thailand and Namibia who are producing health accounts on an annual basis now, and also some countries like Namibia and Burundi who are funding health accounts themselves. So this is still a work in progress, and in some countries that are new to health accounts, They may need some support at the beginning, but we're really seeing a shift now, and donor support is really becoming more targeted.
Thank you very much. Probably now let's just go to, there are a number of questions related to how are certain components within the health accounts framework tracked. And there is a specific set of questions related to the out-of-pocket payment and how it's tracked. One is related to how do we measure out-of-pocket payment versus that of prepayment household contribution to the prepayment schemes. Is the health account equipped to separate the two, and how does it do that is a question, I think, and it cuts across a number of questions that I'm seeing on the screen.
Okay, so the health accounts and the SHA framework definitely can track the difference between out-of-pocket spending and prepayment schemes, and that's actually one of the key objectives of the new framework, is to be able to differentiate between this. And typically, the source of data that we use for household spending can be household surveys, and in many countries, the household surveys will have questions that ask about the type of payments that households have made. Now, we can also triangulate this with data from insurance firms. So when we survey insurance companies, we can ask them how much they received in terms of premium contributions from households, and we triangulate that with the household data to remove double counting, but also to differentiate with out-of-pocket payments.
Okay, thank you so much. There was a question related to how does it help us in measuring efficiency or addressing efficiency issues, considering how often the health account gets done. There was a question related to, for example, if you have outputs and outcome as a spending of this year, how will it affect the next, given that it will affect the next 2 years, how do we go about it? I believe part of it that you have touched on would be, in terms of the frequency of the health accounts that is being done, is going to be able to answer part of the question, really, in a sense. If we, as we go along and conduct health accounts on a regular basis, then probably this question of, given the time lag, how are we going to be able to address efficiency issues using health accounts can be answered. But also it has to do with, given especially in programs related to government, for example, there is always a time lag between shifting the resources between different priority areas, given things like human resource is not as easy to change from 1 year to the next. So it's a long-term process. So in the meantime, even for the countries that are not doing this on a regular basis, there is these health accounts results which might be affecting the health accounts, the country's resource allocation decisions within the 1 to 2 years. It might not be a long time in terms of before it gets acted upon. That's what I can think of. So there is another question related to how does health accounts inform a couple of things. One is, in terms of production, how does it help track spending on pharmaceuticals? Has that been attempted? How does it get tracked within the new updated framework? That's one. And the other question is, in your slide related to the maternal and family planning spending that has been highlighted, which is related to the benchmarking, what are the potential reasons, which is kind of beyond the health accounts, if there is any that you can think of that's driving this?
So in terms of, Tesfaye, your first question was, can health accounts track pharmaceuticals? And yeah, the answer is yes. In the methodology, there's a classification that allows you to track all of the inputs that were used in the production of health goods and services, and pharmaceuticals and drugs would fall under that classification. I believe we're working on further clarifying pharmaceutical spending in the guidance around SHA 2011 to make that process easier for countries to track, but it's something that countries, the 55, however many countries that have already been implementing SHA 2011 are tracking.
And just to add to that, probably I think if you, it's a work in progress, but there is, on the WHO website, we can share with you the link. There are some already country data that would show you the breakdown of spending by inputs where pharmaceutical is highlighted, but with the caveat that it is evolving in terms of the quality of information that's obtained.
So, Tesfaye, your second question was about some potential reasons for the different outputs we're seeing and spending. So I think one thing to mention is that this analysis is very high level, and ideally what we want to do is use to look at the health accounts data in more detail and look at the specific spending areas that are related to those outputs. So for example, when we're looking at percentage of institutional deliveries, we might want to look specifically at curative care spending or spending areas that really affect institutional deliveries more directly. Now, in terms of possible reasons, I think this is something we could look further into. One potential reason that we see is because of referral networks. So spending is driven by high costs in secondary and tertiary levels of care, and if patients are using those levels of care, that can increase the spending, but with the same outputs as another country that might be using their referral networks more effectively. So that's one reason I can think of, but that's a really interesting question, and I think with more country-specific data, we could start to answer that.
Okay, thank you. There is also one quick question related to what is the capacity of health accounts in being used as a modeling or predicting future investments. So that's a quick question.
Mm-hmm.
As you answer that, I'll try to sift through the questions as well. There are a number of questions that are coming in.
Okay, so in terms of using health accounts to inform future investments, we really see this happening a lot when countries are costing out their future strategic plans, using the One Health tool, for example. A lot of countries are using health accounts as a baseline and to inform current spending as a proxy for how spending should increase as well. So health accounts can definitely be used for situational analyses and to provide a baseline, and then it can also help to track spending over time.
Mm-hmm. And I would also add, it can help you conduct gap analyses where health accounts provides the baseline of what you have, and you can project that out over time if it were to remain relatively constant, adjusted for population growth and inflation and these things. But then if you have a strategic plan that's costed or other, a target of what you're trying to achieve, you can see between if things stay as they're going with the health accounts data versus this target, what is the gap that we still need to fill, or is there a gap in funding?
Okay. So I see a lot of questions again related to out-of-pocket payments. Bear with me, we might come back to those. Maybe let's try to get some answers related to so there is a question in terms of the cost of a health account, producing a health account. How much does it cost? I guess the challenges have been answered earlier on, so probably if one of you can, I know it's variable from country to country, but if you can comment on that.
So in terms of the cost of health accounts, the big driver is data collection. And one key component of data collection is household data. So where countries are using their household surveys to collect spending data, the costs are really, you save a lot of time and resources for health accounts. So that's one way where countries can reduce the cost. The cost will also depend on the number of firms or the number of agencies and NGOs that have to be contacted to collect information. So the cost really varies across countries, but I'd say the big driver is the household spending. And we're working with countries to see how that data collection can be made more routine and integrated into existing data collection. So for example, can expenditure, government spending information be collected through HMIS? Or can private sector data from firms and insurance be collected through existing reporting systems? And that will help to reduce the cost even further. And I should mention that the health accounts production tool has also helped to reduce the cost because it automates a lot of the time-intensive procedures in health accounts, like looking at double counting and weighting and mapping.
So probably I think most of the questions also related to Outofpocket are related to how do we, Heather, I think in your presentation you mentioned related to how health accounts can be useful in terms of tracking the spending by beneficiary characteristics. Mm-hmm. There is, by beneficiary characteristics, there is a specific question related to how do we, one, relate health accounts to socioeconomic characteristics, how does that happen practically, given especially that the information might be coming from another data source, which is the household survey. How do you combine that with the other data sources? And there is a related question in terms of how do we take it further and produce something that would be helpful in terms of breakdown of spending by socioeconomic characteristics. So that's a question.
Yeah, and I think it's an important question because I know in several countries where I've worked, they've wondered if high out-of-pocket spending is a result of really people incurring catastrophic expenditures or the more wealthy portions of the population choosing to access care out-of-pocket. In terms of in the framework, Tesfaye mentioned there's this classification called beneficiary characteristics, which allows you to include socioeconomic status as one of the categories in your data to help you cut the data. So you could include that and then do a sub-analysis of the household out-of-pocket spending, looking at the breakdown of spending by the different income quintiles.
Yeah, probably I think there is a quick question related to, again, the Outofpocket. How do we leverage data from the DHS? You mentioned regular surveys as a possible source for tracking out-of-pocket components. So there is a question specifically related to the DHS. Karishmah?
Yeah. So I think that DHS really is really helpful at the analysis stage, and we use DHS figures in the final chart you saw here, looking at efficiency. So DHS really provides it provides the utilization data, and we can compare that with spending to look at some efficiency issues.
Okay. So I'm sorry, there is one more question that I'll be going through. There are, I understand, a lot of other sets of questions. We'll try to answer those as much as we can through a follow-on. But one question that was asked was, in terms of use of the health accounts to inform policy and plans, there seems to be differences. And why do you think that's the case from a country to country in terms of how effectively they use the health accounts results? What's driving that?
Mm-hmm. That's a really good question. I think there are several factors. One is the experience in health accounts. So the understanding of the health accounts framework and what it can do and what types of analysis can be conducted with it. And the second is around the demand for health accounts, and that's really linked to production. So as countries produce the health accounts more and more, we see demand for that data increasing because stakeholders see the richness of data that health accounts give. So I think experience in production plays a factor. I think also having champions within the Ministry of Health and the planning departments that recognize the importance of health accounts and ask for specific analyses. But I think it's also partly a responsibility of the health accounts team to show that to show the value of the health accounts by conducting these types of analysis using more than just health accounts data.
With this, I think we are running out of time. Thank you so much for being part of this technical discussion, and thank you for having these great questions that would help us also further think along what is needed in moving forward. There are materials that you can find on the Health Finance and Governance Project website. You will find it in the www.hfgproject.org. And in addition to that, please email us at hfgproject@aptasoc.com, and we'll try to sift through the other questions that we didn't answer. I apologize, and we'll try to answer them as well, compile and answer them. Thank you very much.